So maybe for organizational purposes, I'll also say hi. My name is Thorsten Dunst from Jena. I'm chairing the session together with Chase here next to me, and we'll go through the abstracts. Some of them have withdrawn or not delivered anything. We'll just call up whoever is there. We go through. The first one's not there. So the second one, who is the second one? Computed tomography, angio, and assessment of the late outcome after OPCAP. Not there, okay. Impact of coronary endarterectomy on the graft patency. Yes, okay.
Great.
That's great. On graft patency in diffuse coronary artery disease patients undergoing coronary artery bypass grafting, an update analysis, and that has been done. Now you have to help me with your name, please.
Zhang He. Good afternoon, ladies and gentlemen. Thank you for the ICC's innovation. The topic of my presentation is clinical outcome of allogeneic iPS-derived cardiomyocyte transplantation for advanced heart failure patients. To our knowledge, heart failure is a growing global public health burden with over 30 million patients worldwide. Patients with advanced heart failure have very poor prognosis. The only effective treatment is heart transplantation, however limited with a shortage of donors. Other treatments can only improve the symptoms for heart failure but fail to restore cardiac function. And cardiomyocyte transplantation has become a promising strategy. Based on these conditions, we designed the study. The study design is shown in this slide. This is a random single-blind, single-center trial performed in 20 patients with ischemic heart failure who are indicated for CABG surgery. The patients aged from 35 to 75 and NYHA classes 3 to 4 and LV injection fractions less than 45%. The key inclusion criteria were shown in these slides. And the primary safety endpoint was freedom from sustained ventricular arrhythmias and newly formed tumors within 6 months after surgery. And the secondary safety endpoints was composed of MESIS and SAE advances. The key secondary outcomes was function change in heart failure. The results, the baseline characteristics were shown in these lines. The two group patients showed no significant difference in baseline characteristics. The patient flow was in these slides, and finally, 9 patients in cell therapy group and 8 patients in CABG only control were finished 12 months follow-up. The SAE and AE and the MESIS rate was shown in these slides. The main change in NYHA classes from baseline to 12 months shows that patients in cell therapy group showed better results. The change in 6 minute walk distance from baseline to 12 months was showed that patients received CABG and iPS-derived cardiomyocyte replacements showed better results. The scale size in CMR scan showed that the scale size decayed in patients who received iPS-derived cardiomyocyte treatment. Finally, all these patients received an ECT scan to show myocardial perfusions, and patients received iPS-derived treatment showed better results. To make a summary, that the study is, to our knowledge, is the first iPS-derived heart reparative therapy clinical study in the world. No sustained ventricular arrhythmias or newly formed tumors were observed. Cardiomyocyte transplantation is a promising strategy for heart failures that develops further research. That's all. Thank you for your attention.
Thank you very much. That was very timely, and it's almost a presentation in German Autobahn speed. So, but it was very good. So there's a question.
Is this phase 1 trial, and the purpose is to test the safety?
Yes. We designed this study to assess the safety and effect of iPS-derived cardiomyocytes. The safety is the main outcome.
Okay, thank you.
And
Thank you.
the stem cells that you transplant, are they pluripotent, or what's the type? There are different types of stem cells that you can use.
This stem cells was inducted by a company which was tested by the third part through a third part test and can be used in hospital for this clinical trial.
Okay, very nice. And then I saw that the adverse events in the stem cell group were, there was 1, there was a lot in the stem cell group, and then there was hardly anything in the cabbage-only group. And then you said it's safe, and is that statistically not relevant, or it looked like a signal as if more adverse events were happening in the stem cell group?
This PowerPoint showed little results of this study, and further results we will publish in paper in further.
Oh, we're looking forward to that. Thank you so much.
Thank you.
Thank you. All right, our next presentation is Beyond Transfusions, Aggressive Patient Blood Management Strategies Improve Outcomes in Robotic-Assisted Mixed Cabbage. And this is by Dr. Art Martella.
Thank you. I will make this move along here. I think both the STS and EACTS have put out statements about hybrid coronary revascularization, and we have adopted that fairly aggressively. It's a combination of both PCI and robotic LIMA to the LAD in most cases. I think one of the assumptions is that there are higher expectations with mixed procedure. Anticipated length of stay, complication rates are all felt to be, they should be lower from our referring physicians. Transfusions in general are bad, whether it's a mix or open. Retained blood should be minimized. Chest tube drainage is not always dependable, and the risk of rebleeding may be higher in these patients when they're undergoing second procedures. I think retained blood in the chest is something that we try to avoid, and so we do open the posterior pericardium, but we also know that 1 in 3 chest tubes is frequently occluded within the first 24 to 48 hours after these procedures. And this is obviously something that we try to avoid. The advantage of the hybrid coronary surgery is sternal sparing procedure and the benefits of the LIMA without the sternotomy. Our approach is a 3-port incisions. We skeletonize the LIMA, anatomical LIMA positioning inside the chest to avoid twisting. We most of the time extend our camera port incision medially and utilize a subcostal stabilizer for insertion. And obviously we use the flow probe on every case. Our goal is to minimize the change in hemoglobin during our procedures. Our starting point hemoglobin is the last laboratory hemoglobin prior to surgery. The end point hemoglobin is the first postoperative laboratory hemoglobin. We also monitor intravenous fluids by anesthesia, and we aggressively manage the chest wall with Surgicel to the mammary bed, fiber and sealant to the chest wall, and barbed suture closure. Again, our results from our study are looking at 288 robotic-assisted mid-cap procedures, the mean age of 66. 121 of these patients were female. 34% had diabetes mellitus. Mean BMI was 32. Isolated LAD disease was 37% or 13% of our patients. Left main disease was were 4 patients or 1.3%, and 94% of these patients were extubated intraoperatively. New postoperative atrial fibrillation was relatively low, 24 patients or 8%. Return to the OR was 0 and 0 CVAs. All these patients were off pump. No intraoperative transfusions were given. 22 patients, or 7.3%, required postoperative transfusions, and no patients required additional procedures, such as chest tubes, which is really one of our main goals. 247 patients received PCI to at least one additional vessel. The mean change in hemoglobin during the procedure was 2.1 grams, and there was a trend towards even reducing that even further. Mean length of stay was 3.6 days with a median of 3.2. 165 patients, or 67%, had mixed with PCI on the same admission, and mix was the first procedure, and the second procedure, 27% with a length of stay that was longer, obviously. 82 patients had PCI delayed with a length of stay of 2.7 days in that group, and 11 patients were able to bypass the ICU, which is also a trend. In conclusion, I think aggressive chest wall management in these hybrid coronary cases can improve patient hemoglobin optimization. Reducing retained blood and risk of rebleeding can at least add to the facilitating of fast tracking of mixed CABG patients. Thank you.
Thank you. That was a great presentation. A couple questions. When we looked at our data on our last 100 robots, the left pleural effusion rate was like 9%, and it was higher than I would have hoped. And many of those patients actually had to have a thoracentesis post, maybe on day 3 or even a week later. What was your pleural effusion rate? What kind of chest tube do you use? When do you take your chest tube out? What strategies do you do to prevent that?
We think that some of that pleural effusion is from the chest wall, whether it's whether it's the port sites or the actual incision. And I think one of the things is careful position of that Blake drain. We use Blake drains posteriorly. If they're at higher risk for bleeding, we'll use a 24 Blake. If they're lower risk, we use 19s. Sometimes we'll put 2 Blakes in, again, if we think they're higher risk. I think, though, our rate of pleural effusion requiring intervention was, I think, about 7 to 8%. So very similar to your experience. But our goal, really, though, in trying to manage the chest wall is to really get that down as close to 0 as possible, obviously.
Sorry. Important concept. I think it's very important that surgeons in general look for ways to conserve blood and not, just say transfusion can be. So the question is, do you have experience with Jehovah's Witnesses, and do you operate in this way?
Yes, and I think there's obviously a lot of carryover with this, in that, a lot of the things that you adopt extend into your open procedures, minimizing IV fluids, minimizing use of sponges. There's definitely, and there's also sort of a Hawthorne effect. You start looking at things, you start impacting on them. But we have had a very good experience. And I think we have more confidence managing a Jehovah's Witness patient, having sort of adopted a protocol for managing patients' hemoglobin.
Titling your presentation aggressive management, I have a question here. Luca Velter from Rome, and by the way, author of the European guidelines about this topic of blood conservation. Did you consider administering erythropoietin the day before surgery to be even more aggressive? Because so-called hemoglobin drift, loss of hemoglobin even in non-bleeding patient, is a thing after surgery. So this might be part of your strategy. Did you consider that?
We are trying to organize preoperative management of patients' hemoglobin, because I would say about 35% of our patients were anemic at some level coming in. And there is a benefit to giving everybody an IV dose of iron prior to surgery. The erythropoietin is a little more difficult, particularly on the inpatient side of things for us in the United States. But I do agree that ultimately would be the best way to manage things. So.
Great, thank you.
Yep.
All right, so the next presentation will be VEST External Support Enhanced CABG, Midterm Clinical Follow-Up of a Multicentric Study, presented by Luca Veltert from Rome. So, there you are.
Happens to be me again.
That's right.
It's an honor to present the job not only of myself, but my good friends Paolo Centofanti from Turin, Italy, and of course Sigrid Sandern from Vienna. Now, there's no point in stressing to the audience of the ICC what is the importance, what is the burden of the coronary illness, and what is the importance of our operation. But still, somewhere from 70 to 90% of the operation are performed with veins 30 years after starting the discussion on graft selection. But this involves tolerating at 10 to 20% early failure, and I mean in the first week, due to technical error or kink compression, and a 50 to 60% on year 5. And this happens despite perfect anastomosis. So there's nothing we can address at the time of sewing to enhance this. So what can we do? There's a couple strategies, one regarding the endothelium, but I'm focusing here on the external support. This device has been around for some time. It doesn't get traction yet, but I think this is about to change. Here is the implant. This is foolproof. You just perform the anastomosis the way you like, then you slide the device around the vein, and then you milk it up. And this is crucially important because you have to obtain absolute adhesion between the device and the vein in order to give the vein the so-called third layer that a vein misses when compared to an artery. So the data I'm presenting here, it's 400 patients, 3 centers, 11 surgeons, which is as close to reality as I could get, and not a huge amount of patients, but yet enough to be adequately powered to draw some conclusions. And due to the sake of time, I would skip all of this, but it is the usual population we see every time, performing 3 grafts on average. Now, the thing I want to show you in this slide is that not all patients received stents on all veins. This was an incidental finding, and this was due mainly at my institution because of financial restraints. So I could not implant every patient with 2, 3, 4 vests, which are costly devices. But this turned to be a major strength of the study. These are the results. These are extremely good results, I wouldn't lie to you. It's better than the Excel trial published studies or whatever, but this is not what I want to show you. This is the crucial point. Comparing the cohort of stented, externally stented veins against the non-stented veins, we found a 4-fold increase in repeat revascularization. Not a tiny bit more, a 4-fold increase. With a p-value of 0.015. This, yes, might be in part due to a selection bias, but having made this myself mostly, I can grant it's not. And looking at the granularity at data, we discovered that there was no difference on the sides of the target vessels, nor on the side of the target vessel. So this seems to have some degree of truth. And this could be a game-changing observation, because still we are carrying the burden of a suboptimal conduit. And I firmly believe that moving on with this publication, and I know there are other studies that are going in the same direction around the world, one day implanting a vein without an external vein will be considered suboptimal, and maybe that day starts today. Thank you.
Yeah, thanks. That's an innovative device. How much is technique and how much is technician of this? You know?
I mean, avoiding that 10 to 20% of acute failure is probably just technique, okay? I wouldn't say that there is an advantage in a kink resistance device, but if you are a careful surgeon, you never put back the heart without carefully inspecting that you are not kinking your device, and this is probably technique. But there is a part that is technology in indeed, because when I saw the data of my 5 years patient implanted with that patent veins not being vascularized, I was convinced in first place.
Please.
Thank you for your presentation, and I'm Yang Yi from Shanghai, China, and I'm very interested in vein because I think the vein had a very huge, space to get improved. And the vest stent is one of the products we can use now. And I also read very publication that the patency is actually didn't improved by using that. So did you analyze the patency of the two groups? Because you just showed the difference of the revascularization.
Well taken point.
Yeah.
This is because in this multi-center study, we could not evaluate every patient from angiography or CT scans. This is why I don't publish this. But I've already published the evidence after 3 years of 2 of these centers with CT scan, and there is definitely a difference in terms of patency, especially in those that reach the so-called PPL, perfect lumen patency score index of 1. And this is the true goal, because the other ones keep degenerating. But if you reach on year 1 perfect lumen patency, then that vein will basically stay in place.
Yes, and I think that the vest stent we can use in the most part of the vein graft, but for anastomosis site, maybe we cannot cover the stent. You know, so do you have some technique for that or not?
Now, this has been a matter of debate in the part, and this is a question I get always when I perform tutoring the first cases around. The firm says you can leave 0.8 millimeters from the anastomosis, and this was done because someone is afraid of the fact that the barbs of the device could damage actually the anastomosis, and it does not. The barbs are absolutely soft. I've never had a single tear on my anastomosis. However, the mechanism on which the device is working is not by absolutely granting a full coverage, is that you don't have to create turbulence in first place, because turbulence multiplies itself on a non-linear relation. So the lower you maintain the turbulence, you have laminar flow on all course. Even if you have the final 2 centimeters of near your anastomosis, it won't happen anything. And this is proven by methodological inspections. Don't take my word for that.
Thank you very much.
Great. Thanks. Next, we have...
I want to ask one more question. How you manage your branches with this device? Any different technique, or you just ligate them?
Okay, the formal statement is ligate them. In reality, nobody ligates this. But avoid using big clips or double big clips, because this makes a kink in the vein, so an invagination in the vein. So you have to keep the vessel as straight as possible. But single clip is absolutely fine.
Okay, next we have off-pump cabbage surgery and left main coronary artery disease, a single-center prospective registry. Dr. Bana.
Good afternoon, and thank you very much, organizers, for giving me opportunity to participate in this meeting. Very exciting International Coronary Congress. So, okay. So, still, we are doing a lot of off-pump surgeries across the globe, but surgeons have a different mindset when it comes to the left main coronary artery disease. We have a lot of doubts. First of all, whether the patient will be able to tolerate the beating heart surgery hemodynamically. There can be a lower risk for vascularization, especially in the lateral and inferior walls. Sometimes we have a doubt about graft patency, and all this can combinedly affect major adverse cardiac event and can, if reflect on long-term survival. What does the literature say? If we see that the debate on on-pump and off-pump is still going on, with both the technique have some advantage on one and other on the other side. But the doubt of the left main and off pump is on a very gray zone still. For example, this paper in 2010 published in Annals Thoracic Surgery shows that the left main coronary artery disease is not recognized as a risk factor after off pump bypass surgery in either in the short and long term period. Whereas the Excel trials side shoot published is off pump surgery was associated with lower rate of revascularization of the coronary artery supplying the inferior lateral wall, and that can increase to risk of 3-year all-cause death compared to the on-pump surgery. Another paper published recently showed that the off-pump is safe, effective operative revascularization technique for the patient with left main disease, even in LV dysfunctions, and it has been found to be associated with morbidity. So we are having a lot of confusion. So our registry was about to give our opinion about left main coronary artery disease revascularization in off-pump by off-pump technique. We have a very high volume of off-pump surgery, almost 95% of the off-pump. You can see about doing about 1,000 surgery per year off-pump. So this registry was started in January 2013 and finished in May 2021. Total number of CABG during this period was more than 6,000. Off-pump was 5,900 plus, and the left main was 28%. 1,673 patients were enrolled in this study. The left main selection criteria was the patient should have a left main coronary artery disease of more than 50%, either by angiography, which is very, very obvious, or if we have a doubt, we have done intravascular ultrasound. The exclusion criteria were very clear. The left main less than 50% if any concomitant procedure was done on the patient, or any time patient has been converted to on-pump surgery. If you see the baseline characteristic of these patients, majority of our patients in this study, closer to 1,400 were males. Diabetes is rampant, closer to 50% patients were diabetic, and significant number of patients were having ejection fraction less than 35%, which was closer to 19.6%. COPD is very, very rampant in our region. That's why 58% of our patient study group were having some sort of chronic obstructive pulmonary disease. If you see the angiographic data, if you calculate the syntax score, all the type of anatomical lesions in the left main disease were available in these patients of 1,600 patients. But more importantly, the circumflex and RCA was involved in closer to 90% patients. The revascularization, none of the patients was in the urgent group, emergency group, but few of the patients, closer to 27% patients were urgent, means that the surgery was done in 24 hours of coronary angiography. If you see the operative detail, we have given a significant number of grafts, which you can see the graft per patient was 3.2. Lima was used in 97% of patients, but bilateral memories, radial was not that rampant, 6.2%, 9%. Total arterial revascularization only 3%. Site of anastomosis, LAD definitely 100%, but the majority of patients received circumflex grafting and RCA grafting. IABP, we are very, very liberal in using intra-aortic balloon pump. I will tell you why. And that's why 10% of our patients received intra-aortic balloon pump, either pre-operative, intraoperative, and immediate post-operative period. If you see the hospital outcome, all-cause death was less than 1%. Post-operative atrial fibrillation we noticed in 7% patient, and 7% patient required at least one shock either for atrial or ventricular fibrillation in post-operative period. Major myocardial infarction, strokes, unplanned surgeries, and even a deep wound infections were very, very less in these 1,600 patients. If you see the 3-year outcome, the major adverse cardiac event means the stroke, death, repeat revascularization was noticed in 3.76% patients, and cardiovascular death was in 2.5% patients. Myocardial infarction happened in closer to 3% of patients, but repeat revascularization was done only in 9 patients. Rest of the patients, the lima was patent, and the culprit artery, which had a MI, was very diffusely diseased, so all these patients were put on medical management. So if you see the surgical management, our strategy is always lima first, and if vein, then the proximal first. In critical left main disease, we do not lift the heart. We just expose the LAD by putting a few pericardial slings. After LAD revascularization, we give them time for heart to recover and then lift the heart in various directions. You see, these are the 3 pericardial slings put on the lateral pericardium and just rotated the heart a little bit to
Need to
expose the
speed up a
LED,
little bit, please.
and then put in a lima to LED. Surgical intracoronary shunt is always deep pericardial stay on the circumflex and RCA and only tissue stabilizer. We don't use heart positioners. You can see these 3 pericardial slings to expose the lateral inferior wall. IABP was used in 10% of patients, as I told you already, some in cath lab, some in preoperative and perioperative period. In cath lab, if there is a EC changes during CAG, critical left main disease unstable angina preoperatively, and if there is a hemodynamic stability ST changes during induction, we have put an intra-aortic balloon pump. In conclusion, off-pump in left main disease does not increase morbidity and mortality in experience of hand surgeons. Our result shows similar to various on-pump surgery registries. Complete revascularization is possible in left main patient with off-pump, reflect the lower MACE and long-term survival in this registry. Especially beneficial in patients with multiple comorbidities. Thank you very much.
Thank you. A bit over, but the point is the concern that you issued in the beginning with the access to the circumflex and issues with left main. I fully agree, and I think your fantastic experience here, congratulations on it, just show that it's oftentimes the technician and not the technique. So that's why I think that's the conclusion. If there are no questions, then we have to move on. Thank you so much, and we'll do. The next presentation has an interesting title, at least for someone in the European arena: coronary artery bypass grafting with arterial conduits for children with Kawasaki disease. And it's from China, and I'm curious what you have to say.
Thank you. I'm from Shanghai, China. I'm present coronary artery bypass grafting with arterial conduit for children with Kawasaki. The Kawasaki disease is common in children. The coronary involvement is about 13% to 25% if the diagnosis and the treatment is delayed. From 2001 to 2023, 44 children diagnosed Kawasaki disease with coronary involvement in Children's Hospital, Fudan University. Male 31, female 13, mean age 9 years old, mean weight 25.5 kilo. The indication of coronary bypass surgery is the severe stenosis and occlusion, and the evidence of global or segmental abnormal contractility, and also the ischemia detection by PET scan. The surgical technique on pump, cardiac arrest with their needle cardioplasia. All grafts conduits are arterial lima 38, beta 3, radial artery 21, composite arterial grafting 9. The mean graft number is 1.5 per patient, and one graft in 57 patients, 2 grafts in 36 patients, 3 grafts in 7 patients. Coronary aneurysm dissection and angioplasty was done in 8 children. There was no mortality, no need bone pump. One case had right ventricle low output, need ECMO pump, and was weaned off. The survival rate was 98% at almost 10 years. One patient lost follow-up. So this is a case at 10 years old, male, left main. We did a composite LITA with LED. This is LPL. The size is about 1 millimeter. So we do radial to LPL first, and then do the leader to LAD, and take the clamp off. We can see the backflow from the radial artery was very good, and do T-graft. And this case is 2 years old at year 2020. You can see the huge aneurysm and small artery, coronary artery. So we have to wait. This kid was on aspirin and warfarin. In 2024, he developed myocardial infarction, and the repeated angiogram showed totally occluded right and left anterior descending artery. So we did right artery to radial artery from ascending to right coronary artery, and Lima to LAD. This is 1 year post-op angiogram, very patent vessels. So we conclude that total arterial grafting for children with Kawasaki coronary disease is feasible, safe, and the long-term clinical results are excellent. Thank you.
Well, congratulations, great cases, very interesting. What was the indication for the coronary angiogram 1 year later? Did you wanted to know what it looks like?
The children had a low ejection fraction with echo.
Okay.
So
all right.
Brings the kid back for angiogram.
Very nice grafts, and so great technique. Again, you know, if the technician knows what he's doing, the outcome is a good one, right? Other questions? Okay, well, I guess.
All right, great. We'll move on to the next presentation.
Thank you.
This will be a presentation by Dr. Pettinari. This is National Trend in Results in Bilateral Mammary Artery Use.
So is that actually, because the numbering here is a little bit off, is there something available for national trends?
What time is that now?
It says number 14. This is, I mean, the display here on our hands is completely off. But that's probably then with the next. So I guess we
can go back to that. That was, I think, the first presentation. Dr. Sato? Okay, so this will be sex differences in coronary artery bypass grafting. Are we all the same?
Okay.
Good evening to everybody. Colleagues. So I do not have conflict of interest. So we know that coronary artery bypass grafting remains the most common cardiac operation worldwide, with more than 200,000 procedures every year. But robust data on CABG in women outcome is weak, and the possible negative effect of femoral gender is the aim of our study, to study this aspect. So we enrolled all patients resident in Lazio who underwent CABG surgery from 2008 to 2022. Our follow-up was 100% complete and certified by the Department of Epidemiology of Lazio, and a total of 20,000 patients were enrolled with 16,000 male and 3,000 female. The study is a retrospective observational study used by database analysis of Department of Epidemiology of Lazio, and we have some clinical data missing, of course, because it's administrative information. Operative or in-hospital mortality included deaths occurring with 30 days after CABG operation, and we made a correlation by anonymous code for the patient with also emergency system and the tax register, including life situation. The statistical analysis were performed in standard fashion, and we can see in the preoperative variables that female patients has very higher profile risk in opposite of male patient with more diabetes, obesity, arterial hypertension, heart failure symptoms, anemia, and cerebrovascular disease, while ejection fracture was higher. We found that female gender was an independent predictor of early mortality, like heart failure symptoms, chronic kidney injury, urgent or emergency surgery, and reduction in left ventricle ejection fraction. While in the long-term mortality, female genders appear to be slightly protective in death. We can see our Kaplan-Meier that after 4 years, the higher mortality of women appears to be disappeared, and the man appears to be to have a higher mortality respect to women, with a higher freedom from revascularization events or heart failure. So collaboration with regional system, I think, is an important step of correctness and truthfulness of data, but we have some limitation of our study. So this is a retrospective. We lost some clinical and echocardiographic variables that we cannot investigate by an anamnestic data set, and we are not able to identify the surgical techniques to discriminate mix or competence or arterial and venous conduits. In conclusion, real-world data of cabbage in Lazio appears to have excellent results in the early and long-term survival. Our data suggests that female sex could be considered an independent risk factor for 30-day mortality after cabbage, but women are also often associated with an higher risk profile. At long-term follow-up, female sex appears to be almost protective, with a higher survival after 4 years. Thank you.
Good presentation. Any questions from the audience?
I have one. Is the difference, because you found something paradoxical, right? You found higher risk during surgery, but better survival in women.
In the long term. Yes.
So is the better survival due to surgery, or is it due to something else?
I think it's due to something else.
Okay.
That women are more strong, probably.
Well, maybe the grafts, I mean, this is the ultimate killer question, but I mean, the graft patency may be better in women, and then you have better treatment efficacy.
We don't investigate this up.
Yeah, I know, that's what I'm saying. It's a killer question. Nobody knows. We don't routinely, or we cannot routinely check, but...
But we don't have difference between the events.
All right, right, okay.
But
yeah.
Maybe.
All right, well, thank you very much. Very interesting. I think then we arrive at the last session, presentation of the session, and that is training in advanced coronary artery bypass surgery in the United Kingdom. And it'll be presented by Jeremy Chan, is that right? Okay, great.
Hi, good afternoon. Hopefully this won't take too long, but thank you for the opportunity for me to present my work on training in advanced coronary surgery in the UK. No disclosure. There is a reduction in both multi-arterial grafting and off-pump surgery in the UK, and less than approximately only 10% of these techniques were performed. And the question is it safe to teach trainee where the trainee has an adequate exposure to these two techniques? So we looked at approximately 300,000 patients across the 24 years who underwent first-time elective or urgent isolated CABG in the UK. We exclude patients who had previous cardiac surgery. emergency or salvage procedure or any concomitant surgery. We then split them into 3 groups, with the control group with on-pump, without multi-arterial grafting, off-pump and multi-arterial grafting, either on-pump or off-pump. We then perform a propensity score matching using inverse probability treatment weight, and we report our continuous variables with median and categorical variable with frequency. Trainee perform approximately 1/4 of the case, but most commonly perform with the on-pump without multi-arterial. So mammary and 2 veins were performed nearly 1/3, with trainee being the primary operator, compared to approximately 17% for off-pump and multi-arterial grafting. Compared the clinical outcome, despite propensity matching, the mortality is higher for consultant or attending performing compared to trainee, which is 5% higher. For on-pump with non-multi-arterial and off-pump, there's no difference in multi-arterial. Trainee takes longer, similar to what is reported in the literature. 4 minutes bypass, 4 to 5 minutes on bypass time, and 2 to 3 minutes on cross-clamp time. That shouldn't be clinically significant. There's higher rate of dialysis and length of stay for consultant performing on-pump without multi-arterial grafting. However, one of the major limitations is whether trainee has done 3 anastomosis or 4 anastomosis and called their case, or done a skin-to-skin. They can both be recorded as primary operator. But regardless, I think trainee in the United Kingdom do have adequate exposure without compromising patient safety. Thank you.
Great presentation. When you say that it was a trainee case, can you go into the actual details of that? I know it's very different in the United States and in UK and Europe. In the United States, the faculty, the attending will still be in the room, still be across the table, even though the fellow or the resident is sewing all those vessels. What is it like in the UK, and what do you mean by it's a trainee case?
So there's no restriction. So even you haven't done the case, I can still put you on there. But the recommendation or the general consensus was if you have done more than 50% of the anastomosis. So let's say you mammary 2 veins, you have 5 anastomosis. If you have done more than 3, technically you can call it the trainee as a primary operator. But as I say, it's completely different from someone doing, from skin to skin to just sewing 3 anastomosis. But they will both be recorded as trainee being primary operator.
Any other questions from the audience before the next session? Great, thank you all very much.